Welcome to the Dr. Lexi Show. My name is Dr. Lexi, and I am a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And during the Dr. Lexi Show, what we are doing is we are having guests on to our podcast to help kind of break down the topics of pregnancy so that you can advocate for yourself and your pregnancy. And today, I'm very excited to welcome a board-certified psychiatrist who's also going to tell us more about the other things that she's kind of boarded and subspecialized in, Dr. Brook Choulet. All right, so before we jump into all the good things that we're going to talk about a ton of good stuff today. I have some questions for you. And the people that watch this regularly or whatever might know this, but you didn't prepare for any questions I was going to ask that were like random. Well, I can't say that then because they would be random. But do you know of the questions I'm going to ask you that are just like 10 questions about?
No,
okay,
I don't.
I always like to tell people that. Okay. She does not know. All right. So these are 10 questions that are kind of in my field, I guess you could say. And I ask these to people because I want people watching and listening to understand whether you are in the field of you're a service worker or you're a physician or you're a teacher or whatever you do for work, or if you don't work, whatever, that a lot of people don't know the answers to these questions that sometimes your provider might think you do know.
We'll find out.
Yes, we'll find out. Yeah. So we're going to see. Okay. Question number 1. What does the abbreviation OBGYN stand for?
Obstetrics and gynecology.
Yes. Very good. Some physicians do not get that right.
Oh.
Just so you know. All right. Question number 2. What do the letters MFM stand for?
Maternal fetal medicine.
God, so good. And that's what I do. And so that's always funny because sometimes people don't know that. And I'm like, that's kind of funny because I send an email ahead of time to, trying to explain what I do. And I include that, which is kind of funny. Okay. Question number 3. How does a provider come up with your due date during pregnancy?
Based on your last menstrual period.
So good. Yeah. And then ultrasounds typically to make sure the period is legit. Yeah. Very good.
Make sure to ask me about that later because I do have a story about my own pregnancy of why we did not know the due date.
Oh, okay. Okay. I'm going to remember that asterisk there. Okay, question number 4. When is a pregnancy considered term?
39 weeks.
Ooh. Yes, but, or yes, and I guess you could say. Could it be term earlier or no?
I want to say it can be term, but it's called like some variation of normal preterm.
So good. So early term can be,
37.
37.
Okay.
Very good. And I think too, when people hear term, like your due date is when you're 40 weeks pregnant.
Mm-hmm.
And then the 39th week, that week before that's a time of term. But 37 weeks is the earliest time of pregnancy would be considered a type of term.
Mm-hmm.
However, 39 is so important because no one's going to induce you prior to 39 weeks because it's early term, unless there's an indication. Right? Yeah. So, but that gets thrown around so much, And like when you, or anybody, like if they have a first pregnancy and let's say they're going for their second pregnancy and they go to the OB provider's office, they might say, was your prior delivery term or preterm? And they just throw that out there like everybody knows what that means. So they should probably say, was your prior delivery prior to 37 weeks or not?
Right. Or how many weeks were you when you
There
delivered?
You go. Right. Like be specific with the question because otherwise it's confusing. And I can't tell you how many times we get a referral in the places I work and it says referral for preterm delivery. And then you just get more of a history. And it's like, well, no, I delivered at 37 weeks and 2 days. Well, that's ultimately considered early term, but term.
Yeah. And some patients may just be embarrassed by not knowing what the doctor may mean that they just may say yes or no.
Yeah, exactly. That's a good point. All right. Question number 5. What is a normal fetal heart rate?
120 to 160.
So good. 110 to 160 is technical. Some people actually kind of like the 120 part. Yeah, very good. All right.
I promise I did not study ahead of time.
I'm telling you guys, she did not know these questions were coming. All right. Question number 6. What is antenatal testing or fetal well-being testing?
That one is tricky. Is that more like the genetic testing before you get pregnant to see if you're a carrier for any specific
No,
things?
and that's why I bring this up because it's a weird term that sometimes OB providers think everyone knows. I feel like that could match because a lot of people say that for an answer. I'm like, yeah, that kind of makes sense. But what this is most of the time typically in the third trimester, but it could be earlier, but typically third trimester. If someone has a risk for stillbirth, like their age is elevated or their weight is significantly elevated, or they have diabetes or high blood pressure, those are some examples. Lupus is an example too. Then we do these things called fetal well-being testing or antenatal testing. And it's to hopefully try and prevent or decrease the rate of a stillbirth.
I did not know that.
Mm-hmm. It's not perfect, but it's when you went to your OB office, did you ever see any patients that had belts on them?
Yes.
Okay. They were doing fetal monitoring.
Okay.
Which is sometimes called fetal monitoring, fetal well-being testing, antenatal testing, antepartum testing, like all these different names.
Yes.
Yeah. So many testings. Yes. There's a handout I have on the website about that too.
Okay.
Super
I'll
helpful.
have to take a look for the next go around.
Yes. All right. Question number 7. How does an ultrasound estimate the weight of a fetus?
I want to say it takes the average of different measurements, such as like femur length and different head circumference, and compiles those percentiles to then determine a fetal weight.
You're so good at this. That's like a really good answer.
Maybe I was just anxious during my pregnancy and I looked up all the answers.
Well, there you go. So, but you retained them, which is great too. But yeah, it takes measurements of arm, leg, head, belly, and then puts them into a computer and spits out a number, basically. Yeah. That's fantastic. That's so good. But you didn't know before you became pregnant, right? Like it's something you looked into and learned. And that's kind of a key point too. Like, how would you have known otherwise? Right? Did they explain it to you when they did the ultrasound and did the weight of the baby? Did someone explain to you how they came up with it?
We asked how they came up with that. I was more focused on length. I'm like, is she going to be tall?
And that's such a good point. So we don't measure the length of a fetus after 14 weeks gestation. And that's a question I never thought someone would ask. And I get asked that all the time.
Wow.
Because when they're little bitty and they look like peanuts, you know, and we're trying to check the due date, we do a length and we call it a crown rump length. And then after 14 weeks, they're so tucked in, you measure the bones and stuff. So you can maybe see the length of the arms and the legs, but you can't measure their height, quote unquote, in utero. Isn't that crazy?
Yeah, they're too curled up in there.
They're too curled up. They're squished in there. All right. Question number 8. What makes up amniotic fluid?
That one, I'm not 100% sure of.
Okay. Baby pee is the main thing. Yeah. Yeah. And it's actually how we can tell their kidneys are functioning well. And it's kind of cool. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
People that have certain risk factors. So someone maybe that's advanced maternal age or other risk factors.
So yes, however, everyone should be offered it. Okay. Yep. And they kind of, I feel like if we roll back 10, 15 years, the answer was always everyone should be offered, but the test available was different for those who were low risk or high risk.
I see.
And that's where we all have this kind of mentality of we shouldn't offer it to everyone because we offered them different tests before if they were lower or higher risk. And now, because the rate of Down syndrome is high in general, but it's not something that is technically, it's like breast cancer in a way. So the genetic stuff that we see for Down syndrome is not that, it doesn't make up the larger portion. It's mainly a sporadic thing.
I see.
You know what I mean? Like when people are like, well, I'm not going to get breast cancer because my mom and grandma didn't have it. Yeah, but you still have a risk because you have breasts, right? So if you have a pregnancy, you still have a risk of Down syndrome, even if no one in the family has it.
And that seems unfair to have different tests too, because then you might wonder, is one better than the other?
And that was the thing. The one they were offering to the higher risk people, which mainly were the higher aged individuals, was better than the other test.
Wow.
Substantially, like from a lower risk person was offered one that was about 85% good at predicting Down syndrome. Other individuals were getting one that was 99% good.
Wow, that's a big difference.
It is. And it was insurance wasn't covering one. The test was more expensive. And now, you know, as years have passed, everyone is able to be offered the 99% good test.
Well, that's good for the general public.
I know, right? It's fantastic. All right. And then question number 10, this is the last one here. What is considered a normal length of a cervix in pregnancy?
That I don't know at all.
I started thinking too, it's not the best of questions because, you know, it changes as the pregnancy progresses. But I think the point for this one for people to listen and kind of learn is that everyone should have the length of their cervix checked once, at least, depending upon other risk factors, once in the pregnancy, sometime between 16 to 20 weeks, typically. I say that, let me correct myself. Sometime between 16 to 24 weeks, typically around the 18 to 20 week time is the key time. And it should be above 2.5 centimeters.
So what should people ask their OBs if they haven't been checked for that?
Will I have an ultrasound to look at the length of my cervix? And if the answer is no, then I would find another OB.
Okay.
But it used to be this big debate of do we do it or not, and is it cost effective? But the long and short of it, no pun intended by being the short of it, but if a cervix is short, there is an increased risk of preterm labor. And then the next step is, can we do anything about it? And we have interventions, particularly depending upon if you had a prior preterm delivery too.
So better to know about it ahead of time than to try and solve an issue if it happens.
Correct. And then this, the part of that, and I'm glad you bring that up. If you go to the website too, there's a handout that goes through 13 questions to ask your OB provider. And this is one of the standards for everybody. And it's at drlexihill.com/advocate. And that's one of the questions. And it's specifically like, how are we going to monitor my cervix and when will we do it?
Okay.
Because it needs to be before you hit the 24-week mark. And they can do it with an abdominal ultrasound or the vaginal probe. Either one is considered okay, but it is standard for everybody to get that, at least that one scan done. Yeah.
Well, that's good to know because I did not ask that question.
And they probably looked at it. And I think this happens sometimes when any kind of doctor's appointment, they might do things and not tell you because it looks good.
Mm-hmm.
And it's kind of like, I don't just want to put reviews on Yelp if they're bad. I want to put good ones too. Right. So, but that sometimes it's a default knee-jerk thing in a doctor's office where they don't give you the good news, but they'll give you the bad news.
Mm-hmm.
I like to give people good news too.
I like that as well.
Right?
Yeah.
I love, and in my field sometimes, and I mean, every doctor has this, right? Where no one enjoys giving bad news.
Right.
So but if you find joy in giving good news, I just try to sprinkle it in as much as I can.
Right. Find as much good as you can.
Yes.
Yeah.
Exactly. All right. These are going to be very quick. They're 10. They're just true, false questions.
Okay.
Just to kind of pick our brains. And then we're going to jump back into things. We're going to jump into, I think, first, the due date for you, because I want to jump into that before we forget. Okay. So true or false? A fetus can have hair while in the womb.
True.
Very good. Question number 2. A fetus can hear. True or false?
True.
Very good. Starting at around 25 weeks. Mm-hmm. Question number 3. True or false? If a pregnant individual eats sugar, this will wake a fetus up if they're sleepy.
False.
Very good. And this one, I've heard some controversy on this, and I've looked up a lot of data, and so y'all can see some links on other items for that. But it can sometimes make them sleepy. You just don't want to be like low blood glucose, because then that's not a good thing, right? So, okay. Question number 4. True or false? Everyone should be screened for diabetes when pregnant.
True.
Very good. Question number 5. True or false? Everyone should be screened for thyroid disorder when pregnant.
True.
False.
False. Okay.
Yeah. A lot of people are screened anyway because they just added into the panel.
Mm-hmm.
But the thyroid changes just a hair during pregnancy. And so sometimes people will get results that look abnormal, but they're normal for pregnancy. Yeah. So, all right. Question number 6. True or false? Someone with 2 prior cesareans has to have a 3rd cesarean.
False.
Very good. All right. Question number 7. True or false? Twins that are the same gender are always identical.
False.
Very good. Gosh, this is great. Okay, question number 8, true or false? No cheese is safe to eat while pregnant.
False.
Very good. Did you eat cheese while you were pregnant?
I did.
And did you know about like what you could or couldn't eat for cheeses?
I thought so. I never know for sure, but I did the best I could.
There you go.
I tried to focus on hard cheeses.
That's a good actually rule, right? And the big rule is pasteurized. They need to be pasteurized because you don't want to get listeria.
But fun fact, Chipotle is not pasteurized cheese.
Now, I want to know how you found this out. You have to tell us because now I'm so curious.
So everywhere I went, I would ask, is it pasteurized or not pasteurized? Chipotle, not pasteurized. What's more confusing is that there's a few, if you're not in Phoenix, we have Zinn Burger here, and there's a few locations in town. Mm-hmm. I went to one location and they told me their salad had pasteurized cheese. I went to the other location, same restaurant, and they told me it was unpasteurized. Like one of you is lying, and I already ate the salad at the first place.
And that's the thing too. It's like, even if you're trying your best to know all the information and get it, sometimes you're going to run into those roadblocks where you're like, I did my best.
Yep. And that's all you can do.
All right. Question number 9, true or false? Someone trying to get pregnant should start taking folic acid before pregnancy.
True.
Very good. Question number 10, final one, true or false? Baby aspirin is an over-the-counter medication that can prevent a certain type of high blood pressure during pregnancy.
False.
True.
Oh,
yeah,
okay.
true.
Okay.
It's the only thing we have to give people for preventing or decreasing their risk of preeclampsia.
Okay.
Yeah, very tiny. And whenever this ends up going up, it's May currently when we're filming this. So yay, May. But May is a couple of things. Preeclampsia Awareness Month. May 22nd is International Preeclampsia Day. And so you can find tons of information all online for that. But preeclampsia.org is one of the best places that I like. They have things that you can do to do your own kind of checklist to see if you're at high enough risk of having preeclampsia or getting preeclampsia rather, to take a baby aspirin to try to prevent it.
Wow, that's a great resource.
Yeah, it's really good. And they have videos on there too that just go through the risk factors, which a video is kind of fun.
Yeah.
They have links. They have personal stories too, because preeclampsia can sneak up and, you don't think you're going to get it. Just a first pregnancy in and of itself, that's a risk factor.
Wow.
Yeah. Which is just fascinating. Or if you also had a sister or a mom, so a first degree relative who had it. So it's kind of interesting because I don't think people really think to ask their relatives about their pregnancies.
Yeah, I don't think so.
I wouldn't think about that.
People often tell their birthing stories, but not necessarily their risk factors.
That is very true. Yeah. And that's the part that sometimes could be important, I guess. But the preeclampsia part is definitely important.
Sometimes, but it seems like everyone has such a different birthing story that no two are alike.
That's a very true statement. I like that. And then for May as well, it's Mental Health Awareness Month, which is a perfect segue into this too. And I'll put some information below for links that I have and that Dr. Choulet has told me about as well, so that you can go to. There's actually a hotline. There's a mental health hotline that actually I got in my email box this month.
Yes.
And I was like, I didn't know that existed. And it's specifically for pregnant individuals, but I know they have it for just general mental health too.
They do have it for general mental health. And then in Arizona specifically, through the U of A Tucson, they just opened up a perinatal hotline for the state of Arizona, going live at the beginning of June.
That's fantastic.
Yeah.
So tons of resources. And I think the more we try to get that information out there at all, the bigger and better.
Yeah.
So, okay. So your due date. Tell me how you didn't figure, or how they didn't know your due date, or how did this work?
So it's kind of a sad story, but I was pregnant in May of last year. I had a miscarriage at 6 weeks. I was told I was actually in London at the time. I had landed in London, woke up at 4 a.m. and started having a miscarriage there. So I went to a UK hospital. They provided excellent care. But what stuck with me is she said, you will never be as fertile as 6 weeks after a miscarriage. So I don't know if that's fact or fiction, but she told us that you would be highly fertile after miscarriage. So I didn't think anything of it. We kept going on with our daily life. We had a trip planned with friends to Vegas. We went to Vegas, then had a trip planned to Machu Picchu. Still hadn't had a period. My mom was totally convinced the day before we left for Peru, you should really take a pregnancy test. And sure enough, it was positive. So I never had a cycle between the miscarriage and when I was pregnant again. So it was incredibly unclear when I actually got pregnant.
So with that and knowing that, and this is a really, really good point, sometimes people don't have a quote unquote last menstrual period. So we can't use our little wheelie thing or the computer system or the app or whatever your provider uses to give you an estimated due date. So in your situation, I'm assuming they did an ultrasound and based it on that?
They did, yeah. So they did an ultrasound, based it on that. And then they also tried to see if that lined up with the last day of bleeding of the miscarriage.
Interesting.
I know.
Okay.
Yeah.
And then did you end up delivering close-ish to your due date?
I delivered, so I wanted an induction. So I delivered 39 weeks and 0 days.
And you bring up a really good point about that too, is that if you are someone who is scheduled for induction, desires an induction, wants to talk to your provider about inducing, the time frame that is safe to do that is 39 weeks. Because if you go earlier, you're getting into the early term portion. And early term, anytime that you're 30, between, I'm getting way too much into the terms, but if you are the 37 to the 39 week mark, you could still have some late preterm, early term complications.
Oh, interesting.
I mean, like there could be more of a NICU stay a little bit or
Uh-huh.
some breathing issues. So 39 weeks, you're good to go. And there also used to be thoughts years ago, well, we don't want to induce people prior to their actual due date because it'll increase their risk of C-section. And they did a huge study and looked into this. Not the case. So if you're in a smaller town or even a bigger town and your provider says to you, you cannot be induced in the 39th week because it'll increase your risk of C-section, that is not a true statement. If it's a hospital staffing issue, that's a different story, But if you're 39 weeks and moving forward, you are in a safe place to go forward with an induction, given that you know your due date,
Mm-hmm.
right?
Right.
So if you hadn't had that ultrasound and you didn't seek an OB provider's care until you were maybe, let's say, 25 or 26 or 30 weeks, and that's what they were basing your due date on, that would be harder, right? So, okay, perfect. Okay, we got through all our questions and we know about the due date, which is kind of interesting. I love that. Okay, so I want to go into a little bit about psychiatry in the pregnant individual. So I see people when they're already pregnant, right? Sometimes preconceptually. And so I'd love to maybe start preconceptually. So if I get a referral and I'm seeing someone who wants to become pregnant, and let's say they have ADHD and they're on medications for ADHD, and I'm trying to talk to them about risk benefits of medications. I have my way I counsel them in general. And I would love to hear your just like basic thoughts on someone. It doesn't have to be ADHD, but something where medication is really important to their day-to-day functionality in lives. And now there's a pregnancy. How do you just kind of navigate that with patients like that?
Yeah. So I'll even back up further to like just a female, maybe 18, maybe depressed, anxious, bipolar disorder, ADHD, whatever it may be. We really have a discussion of, are you planning to get pregnant anytime soon?
Yeah.
So even if someone comes to me pre-pregnancy, not even talking about it, but they're of that kind of fertile age, I'll ask them about their intentions to get pregnant in the future, because that could really change the medication choice. Because I'd hate to start someone on something that works so effectively for them, but that's not safe in pregnancy at all. So that's kind of what my mind goes to when I'm seeing a girl, starting at age 18, is just thinking about what if you were to get pregnant at any time. And then
thank you for that, because
Yes.
that's a conversation that I would say too, if your mental health provider is not bringing that conversation up, maybe you bring it up to them, because I would think that the provider would, but sometimes they don't. So yeah, I love that point.
Right. And life happens too. Things
Yeah.
happen unexpectedly. So I think you bring up a really good point about ADHD. And I think it's just a major risk benefit discussion, because it depends on the level of dysfunction. So if someone doesn't take their ADHD medication and they almost get into car accidents on a daily basis because they can't pay attention while driving, well, the benefit of staying on medication really outweighs the risks of medication maybe for them. So it really just depends on the level of, dysfunction it may cause their daily life. In terms of anxiety and depression, luckily SSRIs are really safe and well tolerated in pregnancy in general. And I tell people so much so that even they're indicated starting at age like 8 for kids. So not only can kids take them safely, women, pregnant, breastfeeding, you name it, a lot of the SSRIs, some more than others, are really well tolerated throughout pregnancy.
Yeah, I like that too. And so if you know someone, I guess, is like, hey, I'm thinking I want to start a family, and they, it would be first go round for them. If they desire, let's say it's for anxiety or depression, if they desire to get off of all medication and they're pretty mild, let's say low doses of medications, what are some things that you can recommend to them while not pregnant to try to see if maybe there's somebody who could manage off of a medicine, just in general, like kind of like options for them?
Yeah, I think a good option is a slow taper. So just seeing if they're able to tolerate kind of stress, anxiety, their mood on a daily basis, while decreasing the dose slowly. So it depends on if someone is a few weeks pregnant, or if they're trying or have been trying for a while, then there's a bit more time. So I think it all depends on that person's preference. And that's why it's not a one size fits all kind of a thing. It's just about that person, what their priorities are, and then how you can help them get to that point. And maybe, getting more family supports and social supports, stress management and coping skills, other tools that they can go to when they're feeling stressed or anxious while not on medication.
Yeah. And I think that that's a big thing too. A lot of just people I know in general, they want the quick fix of like, if I take a pill, it's going to work immediately, which is not always the case in any medication in general, and not have to, I guess, deal with life stressors and things like that. And so finding coping mechanisms, I think, is hard because it does take time.
Yeah. And it's interesting because I feel like there's been a shift recently where people don't want to take medications and they don't want a quick fix necessarily, at least in the mental health world. And they want to solve their issues without medication. So it's all about then building skills and different kind of habits that they can build upon and have a good foundation so that when life does get stressful, and trust me, having a baby at home is very stressful, that you have the tools to then kind of cope with that new life change.
Yeah. And I like to think that when I see someone, I have resources to give them. However, I know for sure that there are patients that aren't getting that from their providers. And it could be because they either don't have the resources or they make the assumption that a different provider is giving them that information. So if you were a patient, just a person in general, pregnant or non-pregnant, I always try to let them know that they're on their insurance card. There's typically a number on the back that gives them access to a mental health provider or somewhere to start. What do you tell people, or how do you tell them to kind of do some research on their own or advocate for themselves?
Yeah. So especially in women that are pregnant or postpartum, there's a group called Postpartum Support International, and their website will be on Dr. Hill's website as a link. But that's postpartum.net. And they have a wide variety of, blogs on there. They have, and even like a PSI certified mental health clinician directory where you can go and look up a PSI certified person that's well-versed in mental health conditions during, pregnancy and after. On their website, you can just go through and put in your state and get a whole list of people that are available.
Oh, that's awesome.
Yeah.
So it's international. So some of them it's country dependent too.
I believe so. I don't want to say that for sure, but I know at least in the US, you can go in and put in your zip or your state and it'll give you PSI certified clinicians in that area.
Got it. And what about for people that don't have insurance? Is that still a pretty big hurdle to overcome, or are there are there items for them to access?
Yeah, it is a big hurdle because I think that kind of care should be available to everyone. And unfortunately, it's not. And so I think that there are a lot of mental health clinicians that offer sliding scale who have out of pocket kind of like self-pay rates that they can accommodate people. And especially the larger groups that have associate level licensees, they have much more heavily discounted rates to allow people to access those services.
Okay. Oh, that's great.
Yeah.
I love that. And I feel like I see a lot of items online too, like whether it's social media or there's a podcast I listen to with Dak Shepard. Have you heard of his podcast?
No, I haven't.
I think it's Armchair Expert. And he has
Okay.
I don't know, he's a very intelligent person. And I love listening to him talk, but he has some of the little advertisements at the beginning. There's one about mental health. Like it's a place you can go, like an app I think you can go to or something like that. And I think those are kind of nice too, because they're pretty accessible and they're pretty decently priced overall. And I think a lot of times too, at least they can give you some skills so that if you can't see them on a regular basis, you can take what you talked about for 30 to 45 minutes or whatever and use it on a daily basis and get a regimen. I think regimens are so important.
Yeah, I agree. The routine and habit, it just promotes good mental health.
Yeah. Yeah. Okay. So then let's think about this. I've never had kids. I've never been pregnant. But I've obviously worked with a lot of pregnant individuals, right? So I try to listen and understand as best I can, kind of trimester by trimester and the stressors that come with each. And I always continue to hear that one of the hardest times is postpartum. Not even just for depression, but just for managing your life. So like, did you prepare for it? Did you know what to expect? Were you overwhelmed? Give us some thoughts because I think it's one of the areas that I want to start getting more information for advocacy. We already have the website you mentioned too, which is definitely going to be there. But any other, I don't know, just preparation or thoughts or support for the listeners? Because I feel like that's maybe one of the harder times.
It is. And I think you know me, and I'm a pretty big planner. So I had my postpartum extremely planned out and regulated. I was like, I'm going to be induced at 39 weeks on the day. My family's going to be here. Make sure my husband's off of work, all the essentials. And so for me, I wanted that very planned out because that felt like something I could do. I always talk to people about productive versus unproductive worries. And an unproductive worry is just these anxious thoughts that you can do nothing about. Like, let's say you think you're going to get fired. Well, you could think of your job loss all you want, and you're not going to do anything with that. A productive worry is something that's actionable. So, okay, I'm worried about the postpartum period. What can I do today to prepare for that? And that's an actionable worry because you can take steps to actually prepare and, make sure that things are, while still stressful, less stressful than had it just been chaotic. So I think it's really important to distinguish between productive and unproductive worry. And postpartum time, luckily, is somewhat of a productive worry where you can put things in place, make sure you have some supports in place, whether it be family, friends, childcare, work leave, things like that you can help kind of prepare ahead of time so you're not scrambling to do those things the minute your water breaks.
Yeah. No, that's actually, I love say it again, what you said for the worries.
Yeah, productive or unproductive worries.
I like that. Yeah. That's really helpful. I'm going to utilize that myself on a regular basis because you're very right. Because I do feel like people sometimes are like, well, it's like the what if game that's played. What if my water breaks? And it breaks, I can't put it back together, right? So some of the things that you can't do things about, but you can prepare for if I deliver early, do I have things set like the nursery or the carrier and the things like that? So
exactly. So I just always ask myself, is there something I can do about this worry? And if not, it's time to move on.
Yep. Okay. I love it. So I think too, what I wanted to talk about was when someone is pregnant and let's say that they start to become anxious, depressed. They've never talked to a mental health provider and they're like, I don't know what to do. I feel like in the obstetrical world, the number one thing that's done is that a SSRI is given to them. And that's an antidepressant. Can you tell us what an SSRI is just for the listeners? Because I use the abbreviation all the time.
Yeah, it's selective serotonin reuptake inhibitor. And they're basically medications that help increase serotonin in your body.
Okay. And so would you say that that is something that in general can be used to treat anxiety and depression or one or the other more so?
Yes, they can be used to treat anxiety and depression, but the big but is if you have a family history of bipolar disorder or you've had a hypomanic or manic episode, which usually PCPs and OB-GYNs do not have time to screen for because they're worrying about a bunch of other things, rightfully so. If you give someone with that history in SSRI, it could really make their mood worse. And what I mean by that is people could have trouble sleeping, they could have racing thoughts, they could have increased suicidal thoughts. Anything like that is a sign that that is not going to be helpful and that they may have an underlying bipolar disorder. So I think, SSRIs can be incredibly helpful in the right population.
Yeah. And that's something that's another thing to add to your list of just being a patient, right? Is like knowing the right person to talk to about that. And yes, your primary care provider or your OB provider is often kind of like maybe a gatekeeper, just like a starting point. Yeah. And we are doing depression screening and your provider should be doing depression screening at your intake and throughout the pregnancy and postpartum. It is a baseline recommendation now to be done regularly. So if you're not filling out paperwork and going through some kind of a screening test, you should be. And if any of that's positive and there's concern, I think this is a really good point, is if a medication is recommended, particularly a type of SSRI, we typically, during pregnancy, Zoloft is a pretty common one because it's an older medication. Right. And you'll find in pregnancy that we use older medications because there's a little bit of data on it versus new medications where there's no data on pregnant individuals. So you'll find that as a common thing. So the medications you see on TV that are brand new and exciting, probably not frequently going to be used during a pregnancy. But that's something that you bring up a good point is if your primary care provider or OB provider puts a medication at you, always good to still see a mental health provider. And I think that's super important. I have known many people that just got started on something and it was never titrated or talked about. They assumed it was going to work immediately. And then they just said they didn't feel right on it. But they never saw a mental health provider.
Yeah, and like you alluded to before, no one really talks about the length of time it may take for you to notice any
Mhm.
benefit. So, unless your provider tells you, don't expect to see any change for 4 to 8 weeks, you might have taken it for 2 weeks and been like, I don't know what they were talking about. This isn't helping at all. And then stop taking it.
Yep, exactly. And speaking of stopping medications, I want to kind of go through this. If you have just, I see that a lot where people are pregnant and they just stop all their medicine, whether they have high blood pressure, depression, anxiety, diabetes, even. They'll just stop everything. And sometimes a pharmacist has told them to do that, or the internet has told them to do that, or they just thought that was the right thing to do. But what are some things, I guess, that you would say to, I don't know if the watch for is the word, or could you just maybe talk about what are some things that actually could go poorly if you just acutely stop one of the medications for mental health?
Yeah, if an SSRI or especially a mood stabilizer for bipolar disorder is stopped abruptly, there's a high risk of recurrence for that mood instability, whether that be a hypomanic, manic episode, depression. And then also, too, even if you keep taking your medications, but you're not following up with your mental health provider, a lot of those medications, even like especially lithium, need to be titrated or a decreased dose very rapidly during pregnancy because of the volume expansion. So even just staying on your medications without seeing anyone could be harmful.
Yeah. And I think that, and this is where I want to go into some explanations on who does what during a pregnancy,
Mhm.
right? So, an OB provider is typically who you go to when you have learned you're pregnant. And that could be an OBGYN, a nurse practitioner, and some people might see someone like me, like a maternal fetal medicine specialist at the beginning.
Mhm.
However, they do not replace your psychiatrist, pulmonologist, the doctor for the lungs, your cardiologist, all those people, neurologist, right? So you still need to see those people,
Right.
right? And so I try to explain that to people. I can manage a lot of things while you're pregnant because a lot of times when your heart doctor or your lung doctor or your whatever doctor knows you're pregnant, they oftentimes don't want to see you
Uh-huh.
because they get nervous as to what to do. But we still need them on board and we need to make sure that you let them know you're pregnant,
Mhm.
right? So, in talking about that too in the mental health world, can you help us understand a little more about if someone is seeking treatment or assistance from someone in the mental health world, what is the difference between a psychiatrist, psychologist, therapist, counselor? I think there's some confusion as to
Mhm.
who should I call.
Yeah, and it's very confusing. There's so many new things out there. I just learned last week that there's now like a certified mental health performance coach. Like there's a ton of things. So there's a lot of misinformation out there. But to break it down, a psychiatrist is a medical doctor who is going to be prescribing medication and or doing therapy as well. So a psychiatrist a lot of times will prescribe, looking at the other medications you're on, looking at where you are, like you said, if you're pregnant, not pregnant, and helping make those decisions. A psychologist can be a PsyD or a PhD who's done special training in different kinds of clinical psychology and is available for things like testing for ADHD, autism, different kinds of testing and therapy. A counselor or, there's LPCs, licensed professional counselor, LMSWs, who are social workers, LMFTs, which are marriage and family therapists.
There's so many
There's
letters.
so many letters, and all of those are essentially counselors that provide therapy.
Okay.
And then the certified mental health performance coach is someone that has not gone through counseling, psychology, medical school. They are simply certified in providing mental health coaching services.
Okay. That's a lot.
It's a lot of letters. I'm constantly learning new letters
A
every
lot of
day.
and if we don't really know the terms and the abbreviations, how would the general
I know.
public know,
Yeah.
right? I just think it's a good thing to I always tell people talking to someone,
Mhm.
whether it is a counselor, therapist, psychiatrist, psychologist, that's always part of what I recommend everybody be prepared for. And I always try to let them know if you don't need it now, have it ready for postpartum,
Mhm.
just so it's available. I do hear people talk to me a lot about, they always say, oh, I am doing CBT.
Uh-huh.
And I know what it stands for, but um, can you give a little bit of an explanation when someone says, and sometimes I think people call it talk therapy. Is that considered the same thing?
It's a kind of talk therapy.
Okay.
So CBT is a kind of talk therapy, just like psychodynamic therapy is a kind of talk therapy. But essentially, CBT is cognitive behavioral therapy, and it's all about linking how thoughts, feelings, and behaviors and it's called the CBT triangle of thoughts, feelings, and behaviors, how they all impact each other. And so by investigating people's automatic thoughts, how they then feel and how they then act, you can really start to unpack the roots of anxiety and depression. And even someone that doesn't have clinical anxiety or depression, but just is a human and struggles with stressors can really benefit from learning that CBT triangle.
Okay. And if someone is doing cognitive behavioral therapy,
Mhm.
is that meant to be done with, we talked about all the letters and all the different
Yeah.
types of mental health providers, a certain type of mental health provider?
A lot of different types offer CBT. So I myself, as a psychiatrist, physician, offer that. The psychologists in my clinic offer that. And also the counselor in my clinic offers that. So it's more about kind of, as a patient, doing your own investigative work on that person's training, their license level, because there, like we said, are a lot of names thrown out there of like,
Mhm.
I'm this or that and specialize in this. But patients can always go to their OB because, like you said, you're kind of the gatekeeper of their care during pregnancy and ask you or someone like yourself kind of who they can go to next.
Okay. And this was an accidental but a perfect segue of asking if someone wanted to reach out to you or your business, how could they reach you? Because I know that sometimes when individuals are at doctors' offices, the doctors themselves don't know who to refer to because they usually have to go through the insurance and all this kind of stuff. And it can be kind of confusing. So if someone was like, hey, I think I would like some type of mental health service and you have various types at your office, it's not just you, right?
Right.
How would they go about reaching you or getting an appointment or figuring out if you had the right thing for them?
Sure. Yeah. Always calling the front desk and speaking to the care coordinator up front can really help kind of get an understanding of what someone's looking for and then pair them with who they would fit with best. So sometimes we get people that call and are just like, I just know I need help. So she'll kind of help unpack, like, well, what are you looking for? Therapy, medication. And so it kind of takes the work out of it for the patient when they're already in a state of being stressed.
And that's the hardest thing, I think,
Yeah.
or not the one of the hardest things is I always try to say, be prepared and get an appointment before you think you need it, or at least your foot in the door.
Hmm.
So that when you're at that time, I usually tell people this when they're in the second or third trimester, because postpartum, being overwhelmed with having a baby now to care for and dealing with all the postpartum things too,
Hmm.
it's not the time you want to sit on the phone with your insurance company for like 5 hours
Yeah.
and be hung up on and then call back and all that stuff. So,
And
okay.
it's similar to other specialties where, you do all this preventative work like a mammogram or, all these colonoscopy. So why can't mental health be that way too, where people sometimes will call us and be like, okay, there's nothing wrong right now, but I have these stressors coming up and I want to make sure I'm like well equipped to deal with them.
Yeah. I never really thought about that, but that makes perfect sense. Everything else is considered to be preventative.
Mhm.
Why wouldn't that be as well?
Right.
I like it. Okay, perfect. I guess other questions. Let's see. For pregnancy, is there anything that you feel like you've seen that you would like to explain to either me or someone listening to in pregnancy that maybe that I don't think about or that we don't think about for pregnancy, specifically with regard to just mental health and happiness and trying to figure all that out?
I think that going home period is really something that I wish was discussed a little bit more, because you have so much preparation on like, okay, the OBs told me what door of the hospital I should enter, how I get up to the labor floor, but there's not really a whole lot of discussion about going home and what that looks like next. I don't mean taking care of the baby. I wish they came with the manuals, but they don't. But in terms of just taking care of yourself, like if you had a tear and had stitches, like what does that aftercare look like? Just using the bathroom or showering. Are there special things that you need to keep in mind? I think just those mama aftercare type things at home,
Yeah.
I wish that was kind of discussed a little bit more.
Yeah. And that's a really good point, I think. And I think there's some attention lately coming to that being called the fourth trimester,
Hmm.
which is weird because to me, trimester means three. 'Cause
Yeah.
it's, right. So, right. I mean, it's
Right.
try. Okay.
Right.
I'm like, do we need to start relabeling them? But, bringing attention to that.
Mhm.
And a lot of information is there and not being shared because so much attention is to getting the baby delivered and not the after the baby is delivered. And then you make a good point too. A lot of the focus is on the baby after delivery. and not on the mom. I will say this. When I used to deliver, I don't deliver anymore. I do, outpatient work, etc. But when I used to deliver, it was always interesting that when the baby came out, any family member in the room would go over to take care of the baby and they just leave the mom.
Uh-huh.
And it's very interesting, right? Like you've spent 9 months roughly growing this child. And then the moment the child comes out, you're like abandoned by everyone. But it's very different and interesting, because to me, that's still my patient, obviously for a longer period of time after that. But that immediate postpartum care is super important too. When you delivered, I know that COVID's been around for a while, so I think that a lot of people had different delivery experiences and maybe even prenatal visits because of not having visitors in the room. But for you, for delivery, were you able to have somebody with you?
I had the whole party with me.
Oh,
so
there you
me, my husband, my mom, and my dad all slept in the hospital room that night.
Nice.
My mom on a chair next to me. I was in the bed. My dad in the lazy boy chair and my husband on the bench on the bed, and the whole gang was there.
The whole shebang. Yeah. And did you feel like you had a good delivery experience?
I did. Yes. I felt like I had a really good delivery experience. It was stressful towards the end because the baby started developing early D cells. And I had my water broken at 7 a.m. And then they did what I didn't even know existed, which was an amnio infusion about an hour after. I didn't even know that was a thing. And maybe you could explain to the audience what that even is. But it was a really good experience overall.
Good. The amnio infusion. And that's the thing too. I do think that it would be great for people to have like a visit before they deliver just to talk about the things that can happen during labor, right? Like decelerations you mentioned where the heart rate goes down, things that you can do to intervene for that. Positional changes for the mom. Right. You could stop any medicine that's helping the mom have contractions. And, or you can, if the water is broken, you can do something called an amnio infusion. So when certain decelerations happen, when the uterus squashes down, it's squeezing. And so it's squeezing on the baby. And then there's also an umbilical cord in there. And so sometimes it compresses that umbilical cord. And so if you can get some more water in there, which we don't make amniotic fluid, but we put, water in there that's meant to represent the amniotic fluid. So we call it an amnio infusion. And you can actually put some nice sterile water back into the uterine cavity to hopefully prevent those decelerations that are caused by compression of the umbilical cord. Yeah.
And one other thing I had no idea about, even as a physician myself, and you'll probably laugh at this. So I thought in the movies, I was just going to like push 1, 2, 3, and the baby would just come out. And then the OB was like, yeah, it could take up to 3 hours. And I'm like, what? I thought this was just like a few pushes and the baby was going to pop out.
Yeah. And people, I say they call it labor for a reason.
Yes.
Right. And also you don't get to eat much. And so I feel like it's very unfair to have someone labor and put all this energy. I mean, there's a lot of energy expended into pushing a baby out. And then you're like basically being starved. Right. You have no energy in your body and you're supposed to push the hardest you've ever pushed in your life. Yeah. No, there's a lot that goes into it. A lot of energy expended.
Yeah.
And it is insane the amount of calories that are needed to have a baby and the time that goes into it as well.
I think the funniest part of my delivery looking back was, like you said, you can't eat. They told me to have some ice chips and some water and whatnot. And my husband comes up right next to me as I'm laying there, epidural in so I can't move, and starts eating a bag of popcorn. And I'm like, I am not a movie. Can you please take your bag of popcorn to the other side of the room?
That's fantastic.
Yeah.
I am not a movie. That's like a really good line, by the way, because I can just see him kind of just like, boo.
Yep.
I like it. Okay, perfect. Well, I'm glad the delivery went well. I think we covered a lot of different things. Can you think of anything else that we should cover or anything else that I don't know, that we haven't gotten to?
Well, I think that the services that you offer at Dr. Lexi Hill are really well needed. And a lot of patients out there could benefit from them because your visits with the OB are so kind of like consumed with just dealing with the nitty gritty of like you said, sometimes not even like, oh, this was normal. It's just about what you should worry about. So having an advocate like yourself who is so well educated and not only an OB, but also an MFM is really kind of awesome that you offer that service to people. So I think that that's a big takeaway is that, finding someone like Dr. Hill to advocate for you and to help educate you more, because maybe all you need is some education and your anxieties of what ifs would go away. So I think having the kind of service you offer is really, really needed.
Thank you. And I know you mentioned you got to go through one of the modules.
Yes.
Kind of. And the modules are broken down into, I think they're pretty explanatory, right? You get like a video introduction. You get a pre-test to kind of see what you do or don't know. Kind of like we started with questions here to just kind of like get your base. Because I think a big thing is we don't know what we don't know, right? And so what if you could get a little bit of information on the things that you can look into? Then it has 3 different videos. It's the expanding your knowledge, kind of telling you about the topic, developing skills, what kind of questions to ask, handouts that you can take to your doctor's office. And then the part I like the best, the impact. Like, what's the whole point of it, right?
Right.
If you learn about this and develop some skills, could you possibly decrease the complications in your own pregnancy, which would be great.
Yeah.
And so that's the impact part. And then you get a post-test to see how you did. It's only 4 questions. I mean, it's just more for fun. And then you get a certificate at the end that says you completed the course, which is, you can hang it on your refrigerator or
I like the handouts too. The PDF handouts are super helpful.
Thanks. And I think that I tried to make it as simple as possible, right? And I hope that they're things that the OBs really find beneficial for patients to use. There's no like stepping on toes. I think as providers, we're all trained to help each other, to make it an easier journey for those that are the patients, so that we get, because I feel like we have to do so much for ourselves right now. So it's happening a lot. Well, thank you for being here.
Thank you for having me.
I appreciate it so much. Thank you so much for joining us today. And again, thanks to our guest, Dr. Brook Choulet. I'm so happy that she was able to join us today. Please don't forget to visit drlexihill.com for more information. You can get your advocacy handout and further information as well regarding resources and links below. I'm Dr. Lexi, wishing you a happy and healthy pregnancy.